I'm assuming that you can hear me on the Zoom, so we'll go forward like that. Hi everybody, my name is Anna, and this is Brittany with Missouri Breaks. I've been at Johns Hopkins University for the past 5 years or so working on my PhD, and part of my project was working in collaboration with Missouri Breaks on the CRST COVID-19 Royacta Hay study, looking at indoor air quality, exposures to commercial tobacco, and the impact of COVID-19 in the community. So just going to go through some background, why we started this study, and then the 3 different parts of the study that I worked on, and then I'm going to hand it over to Brittany to talk about what we're doing on it in the future. So we created the study because Indigenous people are at 3.5 times greater risk of COVID-19 infection compared to non-Hispanic white Americans. And Indigenous people also have high rates of commercial tobacco use, as well as a lot of the community on the Cheyenne River is reliant on propane gas for heating and cooking fuel. And the combination of commercial tobacco with propane gas can lead to a lot of different chemical exposures in the air, through secondhand exposures, just in breathing in through your buildings and in your homes, that could potentially interact with COVID-19 disease outcomes and make the disease worse for the individuals. So we wanted to look at how they're all interacting and what people are exposed to, and if they were exposed to high levels of certain things, if they had worse COVID-19 outcomes. So the study was recruited and happened between March of 2022 and May of 2023. Y'all probably know somebody that was in the study or had the little air monitors in your home, but we only recruited on the Cheyenne River, and we gave priority to different smoking households and people who had COVID-19 recently, so we could capture everything we were interested in. And how it looked was, we had a household with 2 adults at least 9 years apart. We recruited both adults, and each adult gave us a saliva sample and filled out a questionnaire based on different health behaviors, environmental characteristics, nicotine use, all those things. And then also each household got a passive air monitor for aerosol nicotine and nitrogen dioxide, which comes from propane. And the way that these worked were they're just little badges that they set up in your living room or your kitchen for a week. Throughout the week, the chemicals, the air nicotine will settle onto the badge, and then at the end of the week, they pack it up, send it over to me at Johns Hopkins, and I analyzed it in the lab. So it's a really easy way to just measure chemicals inside a room without all of the fancy equipment. You can just hand them out to everybody. You can do a lot with these. So in the end, we had 290 household recruitment, which was 560 participants, and each one of them got an air nicotine badge, and then a small subset of only 100 households got a nitrogen dioxide badge, which works the same way. The badges that we had for the NO2 are a lot more expensive than the nicotine badges, so we were limited by price, which is why we had to do the small section. So for the first part, we looked at commercial tobacco and health outcomes. And all of this was based on the questionnaire data that the participants responded to about commercial nicotine use and then chronic health outcomes that they reported. And this data has already been published in a peer-reviewed journal, the Journal of Racial and Ethnic Health Disparities, last year. It was approved by the tribe and published last year. If you're interested in learning more, you can read it online, or you can ask Ray at Missouri Breaks and she can give you the demo. So we are interested in commercial nicotine use, and I'm using nicotine instead of tobacco because we're also really interested in electronic cigarettes, and that uses artificial nicotine, a chemical-derived nicotine that's put into the device. So I'm using nicotine to cover both traditional tobacco cigarettes, commercial tobacco cigarettes, and e-cigarettes. And we found that 53% of our participants use commercial nicotine in some form. So that's over half of our participants, our 560 participants, using commercial nicotine recreationally. So we took this information and we decided to compare our commercial nicotine users to people that don't use commercial nicotine of any sort, and look at how these different characteristics relate to self-reported health outcomes using our questionnaire. So we looked at long COVID, which is COVID for 4 weeks or more, severe COVID, where we looked at mild, moderate, and severe, self-reported COVID, so answering if you have had COVID previously, and then a bunch of other chronic health outcomes, notably hypertension and high cholesterol, which is what we found significant results for. So when we put everything into our models, we found that commercial nicotine users had higher odds of long COVID. So commercial nicotine users were more likely to have long COVID than non-commercial nicotine users, which is interesting and something that we kind of anticipated because commercial nicotine can damage your lungs. But now it's something that us working with Missouri Breaks, we can now work and target communication and public health outreach based on this information. If anybody has been around Missouri Breaks for the past couple years or something, you've probably seen like one of these or seen our, what was it called? Our little banners that we had.
Good Health TV.
Yes, Good Health TV banners talking about 1.7 times the risk for commercial nicotine users versus non-users for long COVID. But really weirdly, what we didn't anticipate was commercial nicotine users having lower odds or lower risk of some of these health outcomes, like severe COVID, hypertension, and high cholesterol, which if you've ever talked about cigarettes with a doctor or anything, you know that hypertension and high cholesterol are a risk from using nicotine, recreationally, commercial nicotine. So we're really curious as to why this was the case. Why, when we know that these things cause these outcomes, why we're seeing lower odds in our participants. And talking about this for a while, we came to the realization that commercial nicotine use has a lot of stigma associated with it. So people that use cigarettes or use e-cigarettes recreationally might not be going to the doctor as frequently, or when they do go to the doctor, might not be honest about their use, which I've lied to a doctor before, so I mean, I'm not one to judge. Everybody gets into the room with the doctor saying, I'm going to tell them everything. They say, how many drinks do you have per week? I say, 2. And then, meanwhile, I went out with friends, and that was a lie. But the stigma is really big, and it's really powerful when you get in front of somebody that is essentially you feel like you're being judged for your health behaviors and your choices. It's very powerful and it's understandable. So with this information, this is really good information for us to know. So now we can work on addressing this stigma and how people feel and how people who use commercial nicotine feel and their comfort levels in healthcare settings to make sure that they're getting accurately represented in the medical field and they're getting the care that they need to address some of these chronic health illnesses. Hypertension and high cholesterol can be really dangerous in the long term. So something that we're just going to work on, and now that we know, we can address. So that was the first part of the study. The second part of the study was the indoor air with the passive air monitors that I talked about. So the first thing that we looked at was air nicotine, which I told you I was using very intentionally instead of talking about tobacco, because what we're measuring is the actual nicotine molecule and not the tobacco itself. And also we're measuring it from commercial products. We're not talking about religious or sacred tobacco use in this. And when we have these badges in our homes, they detect a bunch of different kinds of nicotine use. So commercial, traditional tobacco cigarettes, electronic cigarettes, and then secondhand smoke in the home if you're smoking or vaping actively in the home, or this kind of newer concept called third-hand smoke. So even if you don't vape or smoke actively inside your home, but you do these outside of your home, when you're vaping or you're smoking, it's kind of like Pigpen from the Peanuts. You're getting these chemicals on your clothes and your hair. You know how people who smoke have that smoker smell? That's what it is. So you're doing this outside of your home, but when you're coming back into your home later that day, you have these chemicals on you, and then throughout the day, they're gonna settle onto your carpets, into your walls, on your sofa and things. So it's still something that you're exposing your home to, even if you're not actively doing it in your home. And then the second thing is nitrogen dioxide, which we talked about from propane use. So propane use in gas stoves and also gas heat are the major exposures to nitrogen dioxide. It comes from combustion. And nitrogen dioxide with air nicotine is associated with a lot of different respiratory health diseases. It can make your asthma worse if you have asthma. It can cause a lot of inflammation in your lungs that makes it then harder for you to clear out things like COVID if you're being exposed to it. So this is just the raw data of all of our air measurements. It's air nicotine is on this level, and then nitrogen dioxide is on this level. And you can see that for the most part, this little plot, the width of this violin, it's called a violin plot, the width indicates the number of households with those levels. So when we're looking at really, really low levels of air nicotine, we are considering those people as non-detect. So most of our households did not have detectable nicotine concentrations, which is great. We want to see people practicing good health habits and not smoking inside the homes, so you're not exposing people like your children or visitors or things to these chemicals. And then for our nitrogen dioxide concentrations, there's a lot more range because nitrogen dioxide can also come in from the outside. It's present in our air, so we're really only concerned about these top group right here as like a high exposure group. So then we also looked at all of our questionnaire data, how people responded to like how their households are having smoke and the rules about smoke, and we found that a lot of households, for the most part, if you say 0 days of smoke in your home, your data, your air monitor is going to show that you had 0 days of smoke. So that's great to see that people who are on our questionnaire and then also having our little monitors in their homes, they know what's going on inside their home. But then you can see these dots right here above the 0 days and above the never smoking, and these are what we called outliers. So these are households that reported no smoking and never allowed smoking in their house, but had detectable air nicotine. And this could be from a lot of different reasons. It could just be third-hand smoke, like I was talking about, the off-gassing of people who are cigarette smokers, who don't actually smoke in their home, but come home, we're still detecting some of that nicotine. It could be because people have kids that are smoking in their home and maybe not telling their parents about it. It could be because they had a visitor come in and smoke. A lot of different reasons. So just interesting to know and important to know like how our data is spreading and why there might be some inconsistencies that we see. But nothing too major. Everything lines up for the most part, so we know we can trust our questionnaire results. And then interestingly, for our propane and NO2 results, we really thought that gas heat would be the driving force of nitrogen dioxide exposures, because in the winter, you turn on your gas heat, the heat is just coming into your rooms, and we think that that would be a lot of propane exposure. But what we found was that it's not really affecting your nitrogen dioxide levels that much. We looked at nitrogen dioxide by heating season, so April to September more or less, October to March, and these lines indicate because they're even, there's really no difference in the nitrogen dioxide levels. So then we looked at cooking. Maybe it's the gas stoves that are driving it. And when we separated everybody by the different kind of stoves that they had, we found that electric stoves have really low nitrogen dioxide levels, and then propane gas stoves had much higher. So we now know that stoves are what's driving the propane exposure and the nitrogen dioxide exposures in your homes. So now that's great. We can now target some different interventions. We can just tell people to use a fan when they're cooking, things like that. Turn your vent on when you're cooking. And then last summer, I came back and Brittany and I went and did some follow-ups with people that had high levels of NO2 in their homes. And we took little NO2 monitors to just measure before and see if there's a nitrogen dioxide leak or where the exposures might be coming from in their home. So on this side, on this axis is the NO2 level, and then on this axis is the household that we went to. So one is one household. And then the blue line or the bottom line is just the NO2 measurement when we entered the home with nothing else, just resting NO2, which for the most part, it's very low. People don't really have NO2 just like hanging out in their homes if they're not doing anything. But then we turned the burners on in their stoves if they had a gas stove. And we found that when we turn these burners on, NO2 just skyrockets. And so we really know it's coming from the stoves. Oh no. Oh, there it is. So especially right here, so this household number 7, they had really low NO2, but they had one of those giant, like, commercial size stoves with like 8 burners. And when we turned on just one of them, it went up so high. So, oh, shoot. So the takeaway from this in our follow-up is just to make sure if you have a gas stove, turn on a vent, put a fan in your kitchen. If it's nice out, open your window just so you can get some airflow in and you're not breathing in that nasty chemicals.
Where was the monitor located at in the household when you like turned on the stove? Was it like right by the stove? Or
we would do it like right by the stove because we didn't want to leave people, we didn't want to use people's gas up,
Right.
really. So what we did was get in, take our like initial measurement by the stove.
Mm-hmm.
We asked if people had cooked or anything earlier that day. So I think on 7 and 11, they said that they had just cooked lunch. So that might be why it's like a little bit higher. And then we turned on the stove burner for about a minute. We didn't want to waste too much propane because these are people's homes and you gotta pay for it. And just turn it on for a minute, let it sit for a minute or so, turn it off, and then measure again.
Okay. And you were just right by the stove when you measured?
Yeah, just standing like you would if you're cooking. We just stood it and hold it right here. If the stove's right here, we hold it right here.
Yeah.
So this would be like a...
turn on the fan and then it went down? Or you just turned it off?
We just turned it off. This was pretty quick. We didn't want to have too much of a burden on our participants, and we didn't want to waste gas since they're letting us take these measurements and they pay for the gas themselves. So,
and honestly, I don't think there were any that had fans that properly ventilate, and that's really common here. Like if there's a hood fan, it just circulates right back into
That's
the
a
room.
good point.
yeah.
That's
That still
important.
helps,
People
though.
don't
That
know
still
that.
works.
It's blowing back in your face a lot of times.
It'll still, even if it's not venting outside, turning the fan on will still increase the circulation in the room, which will help it dissipate faster, even if it's not venting outside. So it'll still do something. It might not be doing exactly what we want it to, like getting rid of it completely, but it's still working. So yeah, that's the NO2 from our follow-up. And then we also looked at volatile organic compounds, which come from things like, if you have a candle that has a really strong scent, that scent is the volatile organic compound. If you clean with bleach, that's a volatile organic compound. So it's a really big range of chemicals, and there's a very big range of different health outcomes and concerns. So we just looked at them in general as just a quick, what's going on. And again, this is the household, and then these are the measurements in parts per million that we found. So one major, our highest level of VOCs in our home, is when we walked into a kitchen, they had just cleaned the entire thing top to bottom with bleach. And we walked in and we could smell it immediately. It smells like bleach in here. And it was a very high VOC level. So another thing to keep in mind, if you're cleaning with bleach or something that's really smelly, the smell is the VOC. And for the most part, we would want to avoid inhaling those for extended periods of time. So if you're really clean and you love a strong bleach to clean up your kitchen, just make sure you're turning on a vent. Again, even if it's venting right back into your face, the circulation of the air in the room will help, and it'll help dissipate those chemicals a little bit quicker than if you just let them sit. And it'll help your breathing also. So then we took all of our, moving away from our follow-up, moving back to the COVID-19 Wayakta study, we took our air nicotine values and our nitrogen dioxide values, and we modeled them looking at different COVID-19 outcomes. So infection, severity, and long COVID, like we saw before. And the way to read these charts are the air nicotine is here, the nitrogen dioxide is here, And this line is essentially our null. So if any of these bars cross that line, it's not significant, so we can't really make any like sweeping accusations or sweeping generalizations and conclusions from this. But we can see here that air nicotine was significantly associated with COVID-19 infection. So what that means is people who are exposed to higher levels of air nicotine had higher odds of COVID infection. And then we also found that nitrogen dioxide was associated with long COVID. So people who were exposed to higher levels of nitrogen dioxide had higher odds and higher risk of long COVID-19 disease, which is not great, but good for us to know. So now we can start thinking about exposures indoors to air nicotine and exposures indoors to nitrogen dioxide and what we can do to curb these so that we can reduce the chances of COVID and reduce the chances of long COVID in our communities. And that wraps up our second part. The final part, I'm gonna hand over to Brittany, where we looked at stress and how people are coping with stress from COVID and what we're doing about COVID and stress.
Could I ask you a question
Of
first about the long COVID?
Yeah.
Those of us who didn't get this disease, didn't get the shots, didn't have to do any of that, what's this all about for those of us who didn't catch it?
Didn't catch it?
Yeah.
You're still at risk. I mean, COVID still exists, so it's now something that we have to think about, like flu. You know how like flu comes around every year? We have to think about how flu is moving in our community and what we're doing about flu, who's getting the shot. We're now starting to think about COVID like we're thinking about flu because unfortunately it's not going away and it's still dangerous to people who have things like comorbidities, who have other health outcomes and other health issues. If they get infected with COVID, they still might be at risk. If you didn't get COVID in the past 5 years, that's incredible. But
Yeah, I did. You know, it might be funny to you, but like for me, it seems to be a dangerous situation here. I didn't catch any of that there, and I'm walking around people that all got the shots and got sick and all that stuff. You guys are a danger to us who didn't catch it. So it's
exactly.
I kind of don't know what to really say to you about that. Maybe you got it, you got the shot, you got all that, and you're a danger to society walking around here for people who didn't get it,
So the goal of this is to make sure that we're not getting people sick, so we're not dangerous to other people. If we know what's making it easier to catch, like for exposures like this one, air nicotine means it's going to be easier for you to catch it. If we can start reducing these exposures and start reducing the risk of getting an infection, then it's protecting our community. So we're not dangerous, because COVID, the asymptomatic, some of us don't know if we have it and we're infectious or whatever, just whatever we can do to reduce the chance of passing it to somebody and making it dangerous for other people around, it's how we keep our communities healthy.
Well, the way I'm thinking is that you have to get everybody to get COVID, right?
Yeah,
And so
we have to get enough people to prevent, because there will be some people that don't ever get it, and some people that are high risk that can't get the vaccine or can't do anything like this. If you get enough people to do these public health practices to prevent passing it on to other people, then there's safe pockets for people that can't do these other things. Does that make sense?
Well, I kind of don't really know what to say because, I'm one of the ones who didn't have to go through any of that. I was on some other medication. My doctor mentioned that if I didn't get it, not to go with what everybody else is doing. So maybe it was these other medications that was helping me out.
Yeah, definitely. It definitely could be that.
and everybody's unique. This is just kind of a general recommendation for what happened with our participants and what happened with the majority of participants. It doesn't happen with everybody, and it's not applicable to everybody for sure. But if we can learn something from this for a bigger part of the community, and a bigger part of our community is affected by this, or is like working under these kind of rules and associations, then it'll help the people that can't or aren't covered under these, aren't getting the vaccines, or can't get the vaccine, or can't, go to the doctor, or things like that. So it's more just like a general recommendation than a rule for everybody, because everybody is unique for sure.
Yeah, okay, thank you.
Yeah, definitely. Yeah, and if like something that works for me definitely doesn't work for everybody, something that works for you might not. It's just a general recommendation because it works for a lot of people, so it might work for you, it might not, we'll see. And if it does, that's great, we'll learn more, and then we'll keep working on that and building it, and if it doesn't, we'll learn and we'll switch, and we'll change.
Well,
And we'll start.
one of the things I think that you can, because you're on the Indian reservation, and as Lakota people, we got an enzyme that you might include into your study about how come us guys didn't take it,
I'm not familiar with that, but maybe we can talk, in the break about
Yeah.
that more.
There's definitely like genetics, all of that stuff plays a role, and that is not even covered on this because this is more just generalized, but people are digging deeper into all of those like genes and things of how our like DNA is built and all like
I think I did
the,
get it, but I never got tested when I did.
what's the word?
Or I just got really bad flu.
But yeah, you know what I mean.
kind of,
Yeah.
What
And I
you're
didn't
saying,
get
because
vaccinated.
on the other part of this Western medicine
Like
that
I
I'm
have
on, I'm taking about 3 traditional medicines that are helping me.
Oh, well, Brittany's about to talk about some traditional medicine and COVID, which you might be interested in. But yeah, so that's the next step, is to start looking at how all of these things interact and what we're doing as individuals, if that's helping, if not. But just as a rule of thumb, this is just like a kind of generalized, it doesn't apply to everybody for sure. And this is just out of the people that had COVID. So the people that we confirmed had COVID, there's a whole group of our participants that didn't have COVID, so they weren't covered by this. And what made them not get COVID versus these people get COVID, I don't know, we're looking into that and to see why some people got it, some people didn't, some people got long COVID, some people didn't. We found that the nitrogen dioxide was a good indicator for people that did have long COVID. It was a good indicator to show that people who had long COVID were more exposed to NO2. So that's just a general advice that we can give people. If you have high NO2 in your home, you might be at higher risk of long COVID because we saw that other people in your community were at higher risk of long COVID and did get it more. So, oh, 5 minutes, I'm sorry. Let me hand it over to Brittany to talk about COVID and stress.
So we did do like the slide where we did test cortisol, just for stress due to COVID-19, and then also if they weren't, forgot about that. So with working participants, we also noticed that these were their sources of stress, and then like way down at the bottom is I'm not really stressed with COVID-19, and then with non-working participants, we noticed that it was also a little bit higher because they were more likely in their homes, they weren't as stressed as COVID-19, but they were worried about the impact on their family, which is probably because their family was also working and they were like worried about whether or not they were going to be exposed. So like I said, just that difference of where it falls at and where that stress was from it. So we also wanted to look at coping mechanisms, and which I found interesting, like I said, was our Lakota practices. And talking to friends and family, exercise is always nice, eating more. But I liked the traditional Lakota practices where they were, because I thought it was interesting, because I noticed a few participants would tell me that they were smudging more. And what smudging is with burning sage, and you're using that smoke to cleanse either like the person, a home, or an object. And so I noticed a lot of people would comment that their belief was that it was cleansing the air of COVID-19. And so I was really interested in seeing where that falls, and I thought it was interesting that the non-working participants had a higher traditional, so it made me wonder if they were also working stage more. Sadly, we don't have any in-depth questions on that, which is kind of where we're wondering where our Lakota people were kind of following on this.
It's just general conclusions. Pop through it.
Pop through it. So because we only have 5 minutes left, we're just gonna quickly just pull these up there. So these are just kind of what she already talked about too already. 1 minute. Oh, 5 minutes, okay. So this is a handout that's in your guys' flyer. This is just kind of what we've been trying to give back to the community. We want something that's very concise and, not just data just throwing at our community. We want our community to know what we're studying, what we're finding. And so then we also put an emphasis on traditional tobacco and commercial tobacco and the differences there. We also did a small sub-study within this group of 20 females between the age, between the ages of 20 and 40, I think, of childbearing age. And we developed this report back form so that way they could see in their homes, maybe things that they could lower to, because we don't want our females having carcinogenics in their homes. We don't want them having endocrine disruptors, because those were also ones that we have on this thing too. And we're just wondering, because we don't want to have pregnancy risks and cancer, and so we're really here. And then also females in general just really understudied with their VOC exposures. And then I just made this basic handout for people just to give back to our participants so that way they could just overall lower their risk to VOCs. Any questions? Sorry to go through that so fast.